Welcome back to Rad Onc Smart Review Thoracic Edition.
Glad to be back.
So imagine you're in the clinic, right? Your patient just beat a locally advanced lung cancer. I mean, they survived definitive chemoradiation, which, is no small feat in itself.
Oh, absolutely. It's grueling.
Right. And they recently transitioned to their consolidation immunotherapy. But today, they're sitting on your exam table and they're gasping for air. They're sweating. Their heart is just racing.
Yeah, that classic terrifying post-treatment presentation.
Exactly. They look at you, terrified, and you look at their chart. And the referral note from medical oncology just asks one single question. Is this radiation toxicity?
Man, I see that note all the time. It's the most common question we get. And honestly, it is the absolute most dangerous question to try and answer right out of the gate.
Because it just forces you into a binary corner, right?
Exactly.
It tempts you into what cognitive psychologists call premature closure. You see a patient who recently got 60 grays to the chest, they have a cough, you look at a scan showing an opacity, and boom.
You just slap the radiation pneumonitis label on them.
Right. It's convenient. But thoracic toxicity isn't hard because the concepts of pneumonitis or esophagitis are, intellectually hard to grasp.
No, not at all.
It's difficult because the symptoms are just wildly nonspecific. And stopping your critical thinking at that first plausible label, well, that's how patients die from missed, totally reversible complications.
Yeah, the problem with the medical oncology referral asking, is this radiation toxicity, is that it anchors your entire diagnostic workup to the past.
Right, to the radiation exposure.
Exactly. Instead of anchoring it to the immediate physiologic threat sitting right in front of you, the question isn't what caused it, not in the first 60 seconds anyway.
So what is the question?
The question is simply, are they stable? Thoracic complications turn lethal through a very narrow, highly predictable set of physiologic failures.
Okay, let's unpack this, because I get the impulse to jump straight to the CT scan. You want to pull up the dose volume histogram and try to find the smoking gun.
We all want to do that. It's human nature for an oncologist.
Right. But let's talk about the room first. Let's anchor this in the specific case we're going to carry through today.
Sounds good.
So we have a patient with locally advanced non-small cell lung cancer. They completed definitive chemoradiation, and they're now on durvalumab.
Okay.
They present with a worsening cough, exertional dyspnea, fatigue, and low-grade fever.
A very messy clinical picture already.
Yeah. And wait, there's more. The imaging shows this patchy lung opacity. It partly overlaps the treated region, but it also extends way beyond it. No single unmistakable new mass, though.
Okay, so a mixed radiographic picture.
Exactly. Plus, they have painful swallowing with reduced oral intake, and they're having intermittent palpitations. So they aren't in florid shock, but, they look miserable. How are you triaging this before you even look at the imaging?
So before I even log into the PASS system to look at that scan, I run them through a strict physiologic filter. I am looking for broken physiology.
Broken, like the word.
Yeah, it's a mnemonic. It helps keep you from getting distracted by, the nuance of their oncology history when their life might be actively threatened.
I love a good mnemonic. Walk me through it.
So B is for bleeding. And we're talking specifically about major hemoptysis here.
Right, not just blood-tinged sputum.
Exactly. R is for respiratory distress. So that means severe hypoxia or a rapidly escalating oxygen requirement.
Makes sense. What's the O?
O is oral intake failure.
Oh, that's a big one.
It is, and people miss it. It's where they cannot maintain hydration or their airway is physically threatened by aspiration.
Okay, and K?
K, spelled with a K for the sake of the acronym here, is for cardiac instability.
Nice save.
Right. So that's hemodynamic compromise, presyncope, or unstable chest pain. E is for esophageal catastrophe.
Like
a suspected perforation or a tracheoesophageal fistula, yeah. And finally, N is neurologic loss. So new focal weakness, bowel or bladder changes, or gait instability that might indicate cord compression.
Okay, wait, let me push back on this a little bit. I've struggled with this in the acute setting. Let's say the patient is coughing up frank blood. That's a clear B in your broken mnemonic.
Absolutely, an emergency.
The instinct is to hold all their treatments, sure, but I also feel this intense pressure to figure out exactly why they're bleeding first.
And that's the trap.
Is it a recurrent endobronchial tumor that's eroding a vessel? Or is it radiation-induced airway necrosis? Don't I need, like, a bronchoscopy to establish diagnostic certainty before I start making massive changes to their oncology care plan?
No, you absolutely do not need diagnostic certainty to secure a threatened airway. I mean, this is probably the hardest mental pivot for an oncologist to make.
Because we're trained to wait for the pass report.
Exactly. We are trained to be highly deliberate, to wait for tissue pathology to correlate imaging. But if a patient is experiencing massive hemoptysis, the mechanical reality of blood filling the alveolar space completely supersedes the etiology.
Right, because if they drown in their own blood, the etiology doesn't matter.
If they asphyxiate, it doesn't matter if the pathology report eventually shows tumor or radiation necrosis. You act on the physiology. You secure the airway, place the bleeding lung in the dependent position, you resuscitate, and you get interventional pulmonology or surgery involved immediately.
Stabilize first, diagnose second.
Always.
Okay, so the immediate threat takes precedence. But looking at our specific case patient today, they are not coughing up blood. They're saturating at, let's say, 95% on room air. They're communicative. They are not hypotensive.
So they don't have those hard, broken escalation triggers.
Right. They are physiologically stable.
Okay, so once stability is established, the pace of the workup shifts completely. Now, you have to reconstruct their exposure history meticulously.
And we can't just rely on that one-liner in the Epic chart that says patient receives 60 gray.
No, that is practically useless in isolation. You need to build a concise exposure map. What was the exact fractionation? Was it a massive central SBRT dose, or is it conventional chemoradiation?
Did they have pre-existing interstitial lung disease?
Right, ILD changes everything. What systemic therapies were concurrent, and what is the half-life of the consolidation therapy they are on right now?
That's huge for the durvalumab piece.
Exactly. And crucially, what is the spatial relationship between their current symptoms and the actual delivered dose distribution?
Okay, let's apply that exposure map to the lungs. The patient has a cough, dyspnea, and a fever. We pull up the CT scan, and there's a patchy ground glass opacity, maybe some early consolidation.
Pretty standard post-treatment finding.
Yeah, and it partially overlaps the treated high-dose region, but it clearly extends well beyond it, like into the contralateral lung.
Which is the red flag.
Right. The easy way out is to just blame the radiation. But I always think of the lung like a house's HVAC system.
Oh, I like this. Go on.
It's like if you come home in the dead of winter and the house is completely freezing, it's really easy to stare at the thermostat, realize it was turned down, and blame the thermostat setting, which in this analogy is the radiation field.
Sure.
But you can't just blame the thermostat without actually going down to the basement and checking the furnace.
That is a great analogy. And in this clinical scenario, checking the furnace means actively building a differential that explains the entire radiographic picture, not just the part that conveniently conforms to your treatment field.
Right, because radiation pneumonitis doesn't usually jump to the other lung.
Exactly. When you see opacity extending beyond the irradiated volume, especially in a patient on a PD-L1 inhibitor like durvalumab, you absolutely have to consider the mechanism of immune-related pneumonitis.
So how do the mechanisms actually differ? Biologically, I mean.
So radiation pneumonitis is fundamentally driven by direct DNA damage to type 2 pneumocytes. That leads to surfactant depletion and a cytokine cascade that heavily features TGF-beta.
Which eventually leads to fibroblast activation and fibrosis, right?
Right. And because it's a direct local injury, it's usually geographically restricted to the dose bath.
But checkpoint inhibitors change that geography completely.
They do, because radiation can act as an in situ vaccine.
Oh, the abscopal effect concept.
Exactly. It destroys tumor cells, releases all these neoantigens, and primes your CD8 positive T cells. When you add a checkpoint inhibitor to that mix, you remove the brakes on those T cells globally.
So the immune system doesn't just attack the irradiated lung tissue.
Right. It can mount a massive inflammatory response against shared antigens in the completely unirradiated contralateral lung. That is why you see that patchy, diffuse opacity everywhere.
Which really means we have to embrace Hickham's dictum here. You know, Occam's razor wants us to find one elegant diagnosis for everything.
We wish it was always Occam's razor.
But the reality of thoracic oncology is that patients frequently have overlapping pathologies. I mean, they can have radiation-induced structural damage that serves as a nidus for a community-acquired bacterial pneumonia.
Yes.
And that can be completely concurrent with a systemic immune flare triggered by their checkpoint inhibitor. The fever and the productive cough should instantly flag an infectious workup rate.
100%. You do not want to blast a patient with high-dose corticosteroids for presumed immune pneumonitis if they actually have an uncontrolled bacterial or fungal infection brewing in that damaged lung.
That would be a disaster.
A fatal disaster. So the role of the radiation plan here isn't to provide a definitive diagnosis. It's a tool to weigh the probabilities. You have to literally overlay the delivered dose distribution onto the new diagnostic scan.
Spatially register them.
Yes. If the opacity perfectly respects the 20 gray isodose line, like it was drawn with a ruler, you lean heavily toward radiation effect. But our patient has bilateral ground glass, so your next move is to coordinate with medical oncology and pulmonology.
Okay, let's talk about that conversation with medical oncology, because, I mean, you know how it is. If I call them and say, hey, I think this might be durvalumab pneumonitis, their first instinct is going to be immense anxiety.
Oh, they hate stopping it.
Right. They don't want to stop a drug that is providing a known overall survival benefit. How do you negotiate that hold?
You base it strictly on severity and the specific agent's pharmacokinetics. If a patient has, say, asymptomatic grade 1 radiographic changes, you can often observe them closely without interrupting the immunotherapy.
Just keep a really close eye on them.
Yeah. But our patient is symptomatic. They have exertional dyspnea and a cough that is altering their daily function. This is at least grade 2. In this scenario, you must hold the checkpoint inhibitor.
You have to explain the biologic reality to them, right?
Exactly. These drugs have incredibly long half-lives. Durvalumab can occupy receptors for weeks after the last infusion.
So holding the dose today doesn't instantly shut off the immune response.
Not at all. It just prevents further receptor saturation while you initiate corticosteroids to actively suppress the T-cell flare. You collaborate on a steroid taper that is slow enough, usually over 4 to 6 weeks, to prevent a vicious rebound inflammation as the drug slowly washes out.
It's a delicate balance. And it makes me think about how we evaluate the lung at the planning workstation in the first place. We constantly talk about the lung as a parallel organ.
Right, the classic parallel structure.
I use the solar panel analogy with residents all the time. A parallel organ is like a massive solar array. If a localized hailstorm or, radiation hotspot smashes a few panels in the corner, the rest of the array still generates enough power to keep the house running.
That's a great way to visualize it.
This is why we care so much about mean lung dose and the total volume exposed, like the V20. But I feel like we oversimplify this in practice. Parallel doesn't mean uniform, does it?
Not at all. And that's a critical failure point in planning.
Yeah.
Think about it. If you are treating a patient with idiopathic pulmonary fibrosis or maybe severe emphysema with massive bullae in the upper lobes, their functional lung architecture is completely heterogeneous.
It's not a pristine field of solar panels.
Exactly. The solar panels in their lower lobes might be covered in mud, functioning at 10% capacity due to UIP pattern fibrosis. If your radiation plan beautifully spares the diseased lung, but heavily irradiates the only remaining healthy parenchyma in the contralateral apex,
then your V20 might look completely acceptable on paper.
but you will functionally cripple the patient.
Wow, yeah. So you have to integrate baseline reserve with the dose volume histogram. Yeah. I mean, a 30% V20 in a marathon runner is a totally different physiologic hit than a 15% V20 in a patient who is oxygen dependent at baseline.
Exactly. And that brings us right back to the multi-system cascade in our case patient. We've assessed the lung, but remember, they also have painful swallowing, reduced oral intake, and palpitations.
Right. They have a lot going on.
If we just treat the lung and ignore the rest, we are totally failing them. The esophageal injury here is actually the linchpin that connects the pulmonary and cardiac symptoms.
I see this happen all the time. The resident's note will just say, grade 2 esophagitis, and the plan is to prescribe viscous lidocaine and see them next week.
Which is terribly inadequate.
Because intake is a vital sign. If they have odynophagia to the point where they are avoiding liquids, they are actively dehydrating.
Yes.
And severe dehydration in a patient with a recently irradiated heart and compromised lungs is a recipe for complete hemodynamic collapse.
It's a domino effect. Radiation breaks down the mucosal barrier of the esophagus. It destroys those rapidly dividing basal epithelial cells. When that physical barrier denudes, you don't just get pain. You create a massive open doorway for normal oral flora.
Opportunistic infections.
Exactly. Candida or even herpes simplex can rapidly invade the submucosa. And if a patient comes in with pain that is suddenly out of proportion to what you expect for the dose they received, or if they have spiking fevers and hemonesis, you have to suspect ulceration, a stricture, or worse.
Like a fistula.
Yes. A tracheoesophageal fistula is an absolute nightmare scenario.
That was horrifying.
The tumor might have been the only structure separating the airway from the esophagus in the first place. As the radiation melts that tumor away, the structural integrity of the wall just collapses.
And suddenly gastric contents and saliva are pouring directly into the bronchial tree.
Which is why I insist on asking highly specific functional questions in clinic. I don't just ask, does your throat hurt? I ask, can you swallow your blood pressure medication? Do you cough violently immediately after taking a single sip of water?
Because if they're coughing after liquids, that's a massive red flag for aspiration or a fistula.
Huge red flag.
It instantly shifts the management from, hey, take some Tylenol, to an urgent gastroenterology consult for endoscopic evaluation and maybe a stent placement.
Yeah.
We cannot manage severe esophageal toxicity blindly from the outpatient clinic.
We really can't. And the downstream effect of this esophageal pain brings us directly to the patient's palpitations. We often write off tachycardia as a secondary effect of pain or fever, or the dehydration caused by their poor oral intake.
Right, sinus tachy from stress.
Exactly. And while dehydration is a massive physiologic stressor, you cannot ignore the heart itself. The heart just took a significant collateral radiation dose.
Cardiovascular toxicity in thoracic radiation is having a massive renaissance right now.
It really is.
For decades, we thought of radiation-induced heart disease as a purely late effect, like something you worry about 15 years down the line in a Hodgkin's lymphoma survivor, presenting as accelerated atherosclerosis or restrictive pericarditis.
But we are seeing acute and subacute events now.
Right. Pericardial effusions, acute arrhythmias, and ischemic events occurring just months after lung chemoradiation.
And this was the staggering, humbling lesson of RTOG 0617.
Oh, what a try.
When we escalated the dose from 60 gray to 74 gray for stage 3 non-small cell lung cancer, the entire field assumed higher dose would mean better local control and better survival, but the 74 gray arm actually had worse overall survival. And when the data was painstakingly analyzed, it wasn't because the cancer was more aggressive. The detriment in survival was strongly correlated with the volume of the heart receiving high doses and the incidence of severe esophagitis.
The mechanism there is fascinating, by the way. It's not that the radiation immediately blows up the heart muscle. The damage is primarily at the microvascular level.
Capillaries.
Exactly.
Yeah.
The radiation damages the endothelial cells of the capillaries supplying the myocardium. This triggers a localized inflammatory cascade, microvascular rarefaction, which is basically the dying off of the small vessels, and eventual ischemic fibrosis of the cardiac muscle and the conduction system.
And that conduction system damage is exactly why our patients' palpitations need a dedicated cardiac workup. We can't just assume it's sinus tachycardia from dehydration.
So what are you ordering?
An EKG and an echocardiogram are mandatory here. Are they in new onset atrial fibrillation because the radiation heavily exposed the left atrium? Do they have a hemodynamically significant pericardial effusion that is starting to restrict ventricular filling? You have to aggressively avoid any unnecessary cardiac exposure during planning and rely on substructure contouring when possible.
That's a huge point. In the past, we just contoured the entire heart sac, and we just looked at the mean heart dose. But the heart isn't a homogeneous balloon of fluid.
Right. It's highly complex.
It's a highly specialized asymmetric organ. Exposing the apex of the left ventricle to 40 gray is wildly different than exposing the left anterior descending artery or the sinoatrial node to 40 gray. We're shifting toward minimizing dose to the base of the heart and the critical coronary vasculature, even if the total mean heart dose looks, quote-unquote, acceptable.
You're touching on the fundamental difference between parallel and serial architectures. We treated the lung as a parallel organ, where total volume matters. But the thoracic cavity is heavily constrained by organs that function completely in series.
Right, the string of Christmas lights analogy.
Let's hear it.
So a serial organ is like a cheap string of holiday lights. If one single bulb burns out, or if you have one tiny focal break in the wire, the entire system downstream just goes completely dark.
Yep.
The proximal bronchial tree, the esophagus, the spinal cord, the brachial plexus, these are all serial structures. You can have a beautifully reassuring mean dose to the airway, but if there's a tiny, localized 80 gray hotspot directly on the cartilage of the main stem bronchus, you are going to cause fatal necrosis.
The history of early stereotactic body radiation therapy, or SBRT for central lung tumors, is practically written in the blood of this exact mechanism.
It was a rough learning curve.
It was. In the early days, we were treating peripheral tumors with ablative doses and getting incredible results. So naturally, the field tried applying those same regimens to tumors sitting right up against the proximal bronchial tree.
And the results were catastrophic.
We saw severe airway necrosis, massive fatal hemoptysis, and tracheobronchial fistulas. The radiation essentially obliterated the microvascular supply to the bronchial cartilage, causing the structural rings of the airway to simply dissolve over time.
Which led to the definition of the central no-fly zone, that 2-centimeter radius around the proximal bronchial tree.
Exactly. It completely changed how we fractionate central tumors. We shifted away from 3 fractions to 5, 8, or even 15 fractions for ultracentral lesions.
Just to give the tissue time to heal.
Right, simply to allow the normal serial airway tissue time to repair sublethal DNA damage between treatments. If a patient comes in with a new, highly focal wheeze, a stridor, or recurrent pneumonias in the exact same lobe we treated, you have to suspect a mechanical airway complication, a stricture or necrosis.
And distinguishing that from a recurrent endobronchial tumor is incredibly difficult on just a non-contrast CT. This is where bronchoscopy isn't just diagnostic, it's therapeutic.
It's vital.
Interventional pulmonology can go in, visualize the airway, debride necrotic tissue, place a silicone or metal stent to keep the airway open, or even employ endobronchial laser therapy to control bleeding.
Let's move to the periphery of the chest, because the chest wall is another structure that plagues us, particularly after SBRT. Say a patient comes in 8 months after treatment, complaining of severe, localized pleuritic chest pain.
Chest wall toxicity is fascinating because the pathophysiology is so different from the lung. It's a combination of rib fractures and intercostal nerve damage.
How so?
Well, radiation depletes the osteoblasts in the rib, preventing normal bone remodeling. Over time, the cortex thins out, and just the normal mechanical stress of breathing or coughing causes a pathologic fracture. The pain can be agonizing, and it often has this neuropathic burning quality if the intercostal nerve gets caught up in the fibrotic scar tissue.
Uncomplicated chest wall pain is usually not a broken emergency, though, but it demands a rigorous evaluation because the major mimic is a recurrent tumor actively invading the chest wall.
Right, you can't just brush it off.
You cannot just dismiss a patient's pain as expected radiation soreness. You need imaging to assess for a destructive osseous lesion versus a classic non-displaced radiation-induced fracture with sclerosis. And the management is entirely severity-based. NSAIDs, gabapentin for the neuropathic component, and time. Most of these fractures will stabilize and heal without any surgical intervention.
But the stakes go through the roof when we talk about the neurologic structures in the thorax. If you are treating an apical lung tumor, like a Pancoast tumor, you are sitting directly on top of the brachial plexus.
Oh, that's a tough spot.
The clinical presentation of radiation-induced brachial plexopathy, the numbness, paresthesias radiating down the arm, profound weakness is absolutely terrifying for the patient.
And distinguishing radiation fibrosis of the plexus from a recurrent tumor infiltrating the plexus is one of the most stressful clinical puzzles in our field.
How do you even tell them apart?
The timeline helps. A little fibrosis usually takes longer to manifest than a rapid early recurrence, but the golden rule is that imaging suspicion is not proof. You might see some T2 hyperintensity and diffuse thickening on an MRI that the radiologist calls likely post-radiation change.
But you can't just trust that.
No, until you have serial imaging proving stability over time or a PET scan showing no avidity, recurrence must stay at the absolute top of your differential.
Because if you falsely label it radiation plexopathy, you condemn the patient to progressive neurologic loss without offering them salvage therapy. And that exact same logic applies to the ultimate serial organ, the spinal cord.
The spinal cord is entirely unforgiving. Radiation myelopathy is a catastrophic, irreversible consequence of demyelination and white matter necrosis within the cord. It presents as paresthesias, sensory levels, weakness, or bowel and bladder incontinence. But here is the critical board and clinical pearl. True radiation myelopathy is exceptionally rare with modern planning techniques and strict adherence to dose constraints.
Which means if a patient presents with those symptoms, it is almost never the radiation.
Exactly. If a patient comes in with new back pain shooting down their legs in a wobbly gait, you must assume they have epidural metastatic disease or a structural cord compression from a collapsed vertebra until proven otherwise.
Because if you wait,
If you assume it's just late radiation change and delay the MRI by even a few days, that patient will become irreversibly paralyzed. You escalate immediately.
I want to take this conversation out of the exam room for a minute and bring it into the dosimetry suite.
Yeah.
Because everything we're talking about, preventing fistula, sparing the cord, protecting the heart, it all happens at the planning workstation. But there's a massive cognitive trap that I see residents and even seasoned attendings fall into. I call it the green checkbox trap.
Oh, I know exactly what you're talking about. The false security of the constraint table. You pull up a complex VMAT plan. The software evaluates the dose volume histogram, and every single metric on the screen is highlighted in green. The cord max is 45 gray, the mean lung dose is 18 gray, the heart V50 is low. The psychological relief is just immense. You think the computer says it's green, therefore this specific patient is completely safe.
But those constraints are not physical laws of the universe. They are population-based statistical probabilities derived from highly heterogeneous historical cohorts. A V20 of 30% might be perfectly safe for a 60-year-old with normal PFTs, but it could be lethal for a patient with severe emphysema.
Right.
When I look at a plan that is completely green across the board, my immediate, deeply suspicious question to the planner is, what did the optimizer sacrifice to get us here?
Because inverse planning algorithms are essentially just mathematical cost function engines. They do exactly what you tell them to do, often at the expense of things you forgot to specify.
Exactly.
If you place a massive penalty on the mean heart dose, the optimizer has to push that radiation somewhere else to cover the tumor. It might spread a low-dose bath across the entire contralateral lung, severely elevating the V5 and risking diffuse pneumonitis.
Or, if you constrain the esophagus too tightly, it might dump an incredibly steep dose gradient directly onto the proximal airway.
This is why summary metrics are dangerous in isolation. You cannot practice thoracic oncology by just reading a spreadsheet. You have to read the spatial dose. You have to scroll through the CT slices one by one. You need to see the exact geometry of the hotspots.
And you have to account for motion, too. A beautiful dose gradient carved tightly around the esophagus looks great on a static planning scan. But the esophagus is a muscular tube that moves with swallowing and paracelsus.
And the tumor moves with respiration.
Right. If your internal target volume, your ITD, doesn't adequately capture that motion, or if your daily cone beam CT image guidance isn't rigorous, that 60 gray hotspot that was supposed to safely sit in the fat between the tumor and the esophagus, well, it might actually be delivered directly into the esophageal mucosa every single day.
Which brings us to adaptive radiation. We hear a lot of buzz about adapting plans mid-course.
Adaptation is a powerful tool, but it must be driven by objective geometric or clinical reality, not just physician anxiety.
Right. You don't just adapt because you're nervous.
If you are treating a massive central tumor, and by fraction 15 it has shrunk dramatically, pulling away from the mediastinum, the entire anatomical landscape has shifted. The lung expands into the void, the heart position changes.
In that scenario, delivering the original plan might heavily overdose the newly expanded normal lung.
Right. You pause, resimulate, and replan based on the new anatomy.
But adapting requires a massive amount of departmental resources. You also have to use these workflows for incident learning. When a near miss happens, let's say a planner forgot to contour the brachial plexus, and you catch a massive hotspot there right before treatment starts, the goal isn't to yell at the dosimetrist.
No, it's a systems issue.
It's to look at the system. Why did the software allow the plan to be approved without a mandatory plexus contour? You use the near miss to build a hard stop in the workflow, removing the trap for the next patient.
Okay, let's synthesize all this complexity and bring it right back to our case patient waiting in the exam room.
The one who is stable but highly symptomatic.
Right, they have a cough, dyspnea, fever, dysphagia, and palpitations. The CT shows bilateral patchy opacities extending beyond the radiation field. They're under Valuemab. What is the concrete action plan?
First, because the opacity extends beyond the high-dose region and the patient is on an immune checkpoint inhibitor, systemic treatment pneumonitis is at the top of my differential. But the fever and the painful swallowing suggest they might be aspirating, so I am actively initiating an infectious workup.
Blood cultures, sputum, viral panel.
Sputum cultures, blood cultures, and a viral panel, yes. Simultaneously, I am calling medical oncology to officially hold the durvalumab. The patient is functionally impaired, so we need to initiate systemic corticosteroids, usually starting around 1 milligram per kilogram of prednisone equivalent.
But you're communicating clearly that this taper will need to be slow and guided by their clinical response.
Exactly. Next, I am consulting pulmonology. Because we have a mixed picture of possible immune pneumonitis and aspiration risk, A bronchoscopy with bronchoalveolar lavage could definitively rule out an opportunistic infection before we heavily immunosuppress them with a prolonged steroid taper.
What about the esophageal symptoms?
For the esophagus, we manage the pain with mucosal coating agents and strictly assess their hydration. If they cannot maintain liquids over the next 24 hours, we admit them for IV fluids and get gastroenterology involved to rule out severe ulceration or a fistula.
And the palpitations.
The palpitations demand an immediate EKG and an echocardiogram to evaluate for a pericardial effusion or a new arrhythmia, rather than just assuming they are tachycardic from the fever.
The clinical logic is solid. But now comes the hardest part. You have to walk into the room, sit down across from the patient who is terrified that the radiation just destroyed their lungs, and explain this to them. What is the exact script you use to communicate this level of uncertainty without terrifying them further?
The key is transparency and avoiding false certainty. I sit down and I say, I have looked closely at your scans and your radiation plan. Several conditions can cause these exact symptoms after chest treatment. And given everything your body has been through, it is very possible that more than one process is happening right now. The inflammation could be from the radiation, it could be a reaction to your new immunotherapy, or it could be a developing infection.
That's very honest.
You have to be. Then I say, our first priority is your safety. We are going to support your breathing and check your heart with an EKG. We are going to hold your immunotherapy for now so we don't add fuel to the fire. We may start some steroids to calm the inflammation, but we are also running tests to make absolutely sure we aren't missing an infection. The goal is to treat the reversible inflammation quickly without overlooking a completely different problem that needs another kind of care.
That is brilliant. It validates their symptoms, explains the immediate interventions, and frames the diagnostic uncertainty as a thorough protective process rather than a failure of the doctor to, know what's wrong.
Exactly. It builds trust.
All right, we have covered a massive amount of clinical and pathophysiologic ground today. It is time to consolidate this discussion into high-yield, rapid-fire takeaways. Let's hit the board pearls. Give me the 6 absolute key pearls from this entire deep dive.
Here they are. Pearl 1. Always start with the treatment intent and physiologic stability. The immediate etiology comes second to saving their life. Stabilize first.
Love it. Number 2.
Pearl 2. Thoracic toxicity is almost always a diagnosis of weighted probabilities. Radiation injury, infection, tumor recurrence, mechanical obstruction, and systemic treatment toxicity frequently coexist. Do not force one label onto a complex patient.
Embrace Hickham's dictum. What's 3?
Pearl 3. Always compare the current imaging with the actual spatial dose distribution. But remember, field conformity supports radiation injury, but it is never absolute proof. Tumors and infections can grow inside a radiation field.
The thermostat in the furnace. 4.
Pearl 4. Understand the fundamental difference between parallel organs like the lung, where total volume matters, and serial organs like the airway, esophagus, and spinal cord, where a single tiny hotspot can cause a catastrophic downstream failure.
Solar panels versus Christmas lights. Number 5.
Pearl 5. Know your hard escalation variables. Worsening intake, increasing oxygen requirements, massive bleeding, hemodynamic collapse, and new neurologic changes. Always remember the broken mnemonic.
And finally, Pearl 6.
Pearl 6. Systemic therapy holds are agent-dependent and complex. Do not invent a universal washout rule. Use multidisciplinary judgment with medical oncology based on the drug's half-life and the patient's oncologic risk.
Excellent. Now, let's run the board. I'm going to hit you with 3 fast-paced clinical scenarios, and I want the attending level answer and the reasoning.
Ready?
Ready? Question 1. You have a stable patient who develops symptomatic pneumonitis while on consolidation systemic therapy. What is the best next step?
Assess functional severity, overlay the radiation dose on the new scan to check the spatial distribution, actively evaluate for an underlying infection, hold the systemic therapy, and involve pulmonology.
And the reasoning.
You cannot assume it's purely radiation and blindly blast them with steroids, which could mask an opportunistic infection. You manage the symptoms while multidisciplinary care sorts out the overlapping probabilities.
Perfect. Question 2. You are reviewing a complex VMAT plan at the workstation. It has a perfectly acceptable mean lung dose and lung V20, but you notice a small, highly focal 70 gray hotspot directly on the proximal mainstem bronchus. Is this plan acceptable?
Absolutely unacceptable without a rigorous spatial redesign and peer review. An acceptable mean lung dose only answers the parallel organ question. It completely ignores the serial organ risk.
You have to review that airway hotspot.
Yes. Can the optimizer push that dose into the tumor without sacrificing coverage? Serial organ hotspots in the airway can cause fatal cartilage necrosis and massive hemorrhage. They cannot be ignored just because the lung constraints are green.
The green checkbox trap in action right there. Final question, question 3. What specific findings definitively shift a routine outpatient toxicity evaluation into an urgent emergency escalation?
Any of the broken physiology findings, a rapidly increasing oxygen requirement, major hemoptysis, an inability to maintain hydration or swallow safely, unstable cardiac hemodynamics, or new focal neurologic deficits.
So what do you do?
If those are present, routine outpatient management stops immediately, and urgent stabilization protocols begin.
Awesome. We have unpacked the acute presentation, the complex imaging overlaps, the biologic mechanisms of injury, the workstation logic, and the exact multidisciplinary communication required to keep these patients alive.
It's a lot to hold in your head, but it's critical.
It is. But I want to leave you with a final provocative thought. As you advance in your career, whether you are a resident, a fellow, or intending, the ultimate lesson in thoracic oncology is to learn to recognize the clinical syndrome without stopping at the syndrome.
Say more about that.
The moment you look at a scan and say, it looks like pneumonitis or it looks like esophagitis, that realization should be the absolute beginning of your critical thinking, not the end of it. Use the spatial dose to understand biologic plausibility, aggressively hunt for competing explanations like infection or recurrence, and when uncertainty alters your management, always choose to escalate and collaborate rather than guessing in the dark.
That is the defining difference between being a technician who just reads a DVH spreadsheet and an oncologist who actively manages the patient's entire physiologic reality.
The stakes couldn't be higher. And speaking of high stakes, in our next discussion, we're going to apply this exact same rigorous discipline to thoracic re-radiation, a scenario where the safety margins practically vanish. Prior plan retrieval is a matter of life and death, and cumulative dose uncertainty dictates every single move you make. Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.